video, I will be going through a step-by-step assessment that should be performed on an athlete if you suspect any type of pathology. It is important to establish a good relationship with your athlete so they feel comfortable and they tell you the truth during this assessment. A medical history is the account of events related to the patient's state of health. In this questioning, you want to ask about the patient's personal medical history, the family medical history, physical medical history, and recent general health status. For history of present illness, you can ask questions like, when did your condition start? What makes your condition better? What makes it worse? Is your condition better or worse at morning or at night? Is your condition better or worse with breathing, eating, urination, excitement, stress, or activity? And have you had any other medical tests done? For family medical history, you can ask them if any immediate family members have had any major health problems recently. After this, you can ask the patient, is there anything else that I would like to know? Next is the neurological screening. The first part of the neurological screening is the cranial nerve assessment. The first thing I do is test the olfactory nerve by having the patient close their eyes and smell. The second nerve I test is the accessory by doing a resisted shoulder shrug. Next, I test the vestibulocochlear by having the patient close their eyes and tell me which ear they hear sound in. Next, I test the optic nerve by having the patient keep eye contact with me and tell me which side of their body that they see movement out of. Next, I do the trigeminal sensory by doing facial sensation. I touch the patient's face on both sides and ensure that the patient feels sensation equally on both sides. Next, I test the facial nerve by having the patient smile, frown, and make a mad face. Then the trigeminal motor nerve by having the patient clench. Third jaw, and then the glossopharyngeal by having the patient swallow, then the vagus by having them say ah, and then the hypoglossal by having them stick out their tongue. Next up is the trochlear and abducens nerves. You want to test these by having the patient follow the pen light and test their upward eye movement, downward eye movement, and their lateral right and left eye movements. After that, you test the oculomotor nerve by doing Pearl, making sure the pupil is equally dilate on both sides. Lastly is the optic nerve. You want to assess this by having the patient read near and far. In this, I have the patient read a paper next to me and then read a box far off in the distance. Next, I'm going to test the upper extremity dermatomes by doing sensation. First is C4 on the superior shoulder, then C5 on the lateral upper arm, C6 the lateral forearm, thumb, and second finger, C7 the middle finger, C8 the medial forearm and the fourth and fifth digits, and T1 the medial upper arm and elbow. Next, L1 the inguinal area, L2 the proximal anterior thigh, L3 the distal anterior thigh, L4 medial lower leg, L5 lateral leg, S1 lateral foot, and S2 the proximal posterior leg. Sensation will be performed bilaterally for all dermatomes. Next is motor testing of the dermatomes. First, C4 resisted shoulder shrug, C5 resisted shoulder abduction, C6 resisted elbow flexion and wrist extension, C7 resisted elbow extension and wrist flexion, and then in the lower extremity, L1 resisted hip flexion, L3 resisted leg extension. L4 resisted dorsiflexion, L5 resisted great toe extension, S1 resisted plantar flexion, and S2 resisted knee flexion. Next, I will have the patient close their eyes and I will ask them if the sensation they are feeling is either sharp or dull. This is an assessment of sensory function of all extremities. Light and dull should be performed on both extremities to account for any deficits that would be experienced non-bilaterally. Next, I will perform an upper extremity deep tendon reflex assessment. First is the brachioradialis, second is the biceps, third is the triceps. Next is the lower extremity evaluation. First is the patellar tendon, then is the Achilles tendon. All of these tests will be done bilaterally so that you test motor function on both extremities. Next is a gait analysis. During the gait analysis, you are looking for an antalgic gait, see if the patient has a limp. You're looking for hip hiking, looking for swinging of the legs. You are analyzing the knees to see if they have an excessive inward rotation or excessive outward rotation. And you are looking at the feet to see if they have excessive inversion or excessive eversion. You're also assessing the walking status of toe off, midfoot, and planting. For the balance assessment, I completed the Romberg test. For this test, you have the patient stand with their 2 feet together, have them close their eyes, tilt their head back towards the ceiling, bring both arms up to 90 degrees, and then with their index finger alternate bringing each index finger to their nose. Also, to assess balance, you can have the patient walk along a line that you can either tape down or you can have them follow a line, and this assesses balance by having them do tandem gait along the line. Next is the cardiovascular assessment. First, you want to palpate the carotid pulse. Next, you want to observe the jugular venous pulse and assess for jugular vein distension by having the patient look away from you. Next, you want to inspect and palpate and find the apical impulse. The apical impulse is between the fifth intercostal space, and you want to note if there's any heave or thrill. Next is auscultation of heart sounds. You want to listen to the heart sounds and make sure there is a normal lub-dub. The first zone is the aortic listening zone, located just to the right of the sternum in the second intercostal space. The second is the pulmonary, and that's located on the left second intercostal space. Then the tricuspid, located in the left fourth or fifth intercostal space. Last, the mitral zone in the fifth intercostal space on the left side in line with the midclavicle. Next, you want to assess the lower extremity vascular system. First, find the femoral pulse. Then you want to inspect the legs for color, size, and see any lesions. Then the dorsalis pedis pulse. Then the posterior tibialis. Then you want to check cap refill. All this will be done bilaterally. After checking cap refill, you can slightly bend the patient's knee and check the popliteal. Next is a respiratory inspection. You want to look at the thoracic cage. You want to look at the patient's skin color and condition, the person's position, facial expression, use of the accessory muscles, and level of consciousness. You want to assess skin temperature, moisture, and confirm symmetric expansion of the thoracic and detect any lumps, masses, and tenderness. Then you want to assess respiration rate, rhythm, and depth. Next is respiratory auscultation. You want to listen to 4 spots on the anterior portion of the lungs bilaterally. At each position, make sure you instruct the patient to take a deep breath in and a deep breath out. Next, you want to do the posterior aspect of the lungs. Then there are 7 spots bilaterally on the back that you want to listen to bilaterally. They're along the spine of the scapula, the medial border of the scapula, and the inferior angle of the scapula. You want to make sure you always listen bilaterally. The normal breath sound is a low-pitched, soft intensity swooshing sound. Next is pulmonary percussion. During this stage, you are listening for hollow and dull sounds and making sure they are in their appropriate places. If you hear a dull sound over where it's supposed to be hollow, you may suspect a hemothorax. Lastly is the abdominal assessment. First, you want to look at the abdominal for inspection. You want to look at contour, symmetry, look at the umbilicus, and look at the skin for any rashes or skin conditions, and then look for any pulsation or movement. Then you want to go to auscultation. In auscultation, you are listening to bowel sounds. Normal bowel sounds include tinkling, gurgling, or clicking. You want to listen to each quadrant for about 5 to 10 seconds. And you should hear about 5 to 35 sounds per minute. If the patient is suffering from absent bowel sounds, they might be suffering from a bowel obstruction and they need to be referred to the emergency department for an inspection of the bowel. Next, you want to do percussion of the abdomen. You want your first index finger, the DIP, touching the skin, and then a DIP of your other finger to tap that finger. You want to tap twice and listen in every quadrant. When percussing the abdomen, you are listening for dull and hollow sounds. Dull sounds are organs like the liver, and hollow sounds come from organs like the stomach. Lastly, you want to palpate the abdomen. First, you want to do light palpations. Second, you want to do deep palpations to elicit any rebound tenderness. And lastly, you want to do deep palpations to touch the liver and the spleen. After you finish your full physical eval, you want to ensure that the patient feels comfortable and you want to ask them if there's anything else that they would like to tell you that you have left out over the course of the evaluation. You also want to make sure you complete every test and every palpation bilaterally to ensure that whatever you feel is either normal or abnormal to confirm a pathology.